We're going to hear now from Mike Smith. They is a non-binary queer settler currently working as the Game and Health System Navigator with ACT in Toronto. Mike has worked as a crisis support worker with queer and trans youth in Toronto, as well as a learning facilitator for EGAL in Canada. Mike draws off their experience with mental illness, ex-gay conversion therapy, and substance use to inform their work at ACT, and with their personal advocacy work. When time and spoons permit, they work to promote queer and trans inclusion in Mormon communities and support survivors of ex-gay conversion therapy. Welcome, Mike.
Is this yours, Matt? Hi, everyone. My name is Mike Smith again, and today I'd like to share with you the context within Toronto. So just for the epi nerds out there, I just want to give a quick snapshot of what's happening in Toronto. Unsurprisingly, gay, bisexual, and queer men in Toronto are disproportionately affected by STBBIs, including HIV, syphilis, and gonorrhea. From 2016, 65% of all new HIV cases were among GBQ men, and 85% of new syphilis cases, a total of 717, were of GBQ men. Also, 45% of new gonorrhea cases, a total of 1,305, were among GBQ men. In an effort to understand why these rates continue to be so high, a series of consultation activities were conducted, including an open community consultation during Pride and 3 focus groups held last month, a group designated for the BIPOC community, one for the trans and non-binary community, and one open to the general community of guys into guys. Drawing largely from the data gathered by Drawing largely from the data gathered by CBRC's 2015 Sex Now data, our consultation questions and activities were designed to investigate experiences of anti-gay prejudice, shame, discomfort, and discomfort in healthcare settings, especially among primary care providers in sexual health clinics and mental health and substance use settings. Today I want to share some of these narratives with you and focus on the findings related to sexual health clinics in Toronto. Okay, so first, informants reported a lack of sexual health services for gay, bisexual, and queer men. And it is important for community members to have access to GBQ-specific services and spaces, and this need comes greatly from frequent experiences of homophobia in clinical settings. Unfortunately, GBQ-designated services are bursting at the seams in Toronto, and community members are asking for services with hours and locations that are more convenient to them, such as evening and weekend operating hours and services located outside of the downtown core. This is especially relevant for people of color. Second, informants report that the high cost of PrEP and PEP is the main barrier to accessing these preventative technologies in Ontario. Some informants also report that the Ontario Trillium drug benefit is insufficient in providing the financial support required to access this medication, and additional financial support is required. Third, informants report that they are being shamed for their sex practices in sexual health clinics, even in GBQ-targeted clinics. I'd like to share a few quotes from the community consultation and focus groups regarding instances of sex shaming. Okay, so in the pink bubble. So many times I have gone to a sexual health clinic and was asked, why do you have sex without a condom? Or why do you go to the bathhouse so frequently? We have to ask ourselves, in regards to health promotion, what sort of impact does this kind of sex shaming have on clients? Does it reduce risk, or does it reduce the uptake of testing and treatment services? Our findings suggest the latter. To the purple bubble. I prefer to get tested at my doctor's office. I have been to a sexual health clinic, and every time I get a finger wagging. Makes me too uncomfortable. This informant and many more are choosing to avoid services because of repeated negative experiences. If we want to increase uptake of combination prevention services, then we need to keep all avenues open and begin to think about service user retention. And to the blue bubble. When I used to go to the sexual health clinic, there was a nurse that would get upset that I had been there too often. I heard her refer to me as a regular. Perhaps we can explore other intervention options than expressing frustration towards a service user. I believe compassion must be reprioritized in Toronto sexual health services. Privacy violations were reported as a main source of anxiety for informants, especially in crowded waiting rooms. Service users feel fear about seeing someone they know and dread having their name called out in front of large numbers of people in waiting rooms by clinic staff. This begs the question of whether we can design services that would avoid these privacy violations and make accessing treatment and testing services a more comfortable experience rather than distressing and intrusive. And lastly, informants reported many experiences of racism, transphobia, and ageism in clinics. Is this inevitable, or can we develop a service where experiences of oppression are reduced to a minimum level? I interpret this as an HR issue. With proper screening and training of staff, including administrative staff and volunteers, I believe this is possible. Through our formative research efforts, we have a theory that we hope to explore and investigate further, which is, service users in Toronto will access HIV and STBBI testing and treatment services more frequently if we can address affect. So look at feelings of comfort. We need to explore ways to balance exceptional service user experience with efficient operations in order to address high demand for services. Connection. Provide more opportunities for service users to access care when their identity is reflected in the imagery, staff representation, and cultural-specific service design. Confidentiality. Make every effort to create discrete and private testing treatment services. Convenience. Increase service hours, schedule service hours during evenings and weekends, and open new services outside of the downtown core. And choice. Empower service users to have an increased element of self-determination in the way they access services. Great. We have an opportunity to test this theory at ACT's new Rapid Point-of-Care HIV testing pilot project in partnership with Parkdale Queen West Community Health Centre. To measure our impact, we are encouraging service users to evaluate their experiences with testing services in an effort to determine the effectiveness of a more client-centered service model. Evaluation of sexual health services is a new experience for Toronto community members, and many are excited to share their perspectives. We recognize that this strategy will not impact all service users equally, and there is more we need to do to reach more marginalized communities. For the next fiscal year, we plan to integrate a genderless service in our existing service model. This will attempt to address the barriers that many trans, non-binary, and two-spirit folks experience when accessing services in gendered spaces. As many of you can relate, gendered medical health services are often sources of gender policing, anti-trans prejudice, and even violence. And a genderless sexual health service was marked as a major priority for our two-spirit community members. A genderless service would also invite trans women who feel they do not pass enough as female and therefore do not feel comfortable to access any gendered spaces. For autistic GBQ men, we hope to develop a number of different access aids designed to help ease the anxiety of accessing a new service in an unknown environment. This request for more trauma-informed care comes from informants of ACT's HIV and ASD needs assessment conducted by Brandon Wolf and Ryan Lisk earlier this year. And for sex workers, we hope to collaborate with organizations such as Maggie's, Butterfly, and Women's HIV/AIDS Initiative to fill a need once addressed by an organization called Street Outreach Services in Toronto that provided support for male-identified and trans sex workers. Our formative research in the next quarter will determine the direction of this project. I would like to acknowledge the great responsibility that ACT and other organizations represented here today has to address the needs of all community members and not just the privileged among us. One of the ways ACT is honoring this responsibility is working closely with Paid Advisory Committee, comprised of a diverse group of service providers and community members, including folks from different ethno-cultural groups, gender identities, and ages. We feel this is an important step to develop more trust and engagement with diverse communities in Toronto. Interventions for year 2 of this project will also include health systems evaluations, working towards developing interactions that have yet to be determined, but will include the following. Facilitate the development or exchange of KSAs to better provide services. This could mean developing new learning programs or coordinating opportunities of existing learning programs for healthcare workers, or working with public health nurses in Toronto Public Health to identify and address gaps in health services. We will definitely be advocating for the universal coverage of HIV-related medications for those living with and at risk for HIV in Ontario. I'd like to thank you, and I'd love to hear back from you with any feedback or ideas on how to propel the work forward in Toronto. I'd also like to thank my supervisor, Tyler Morton, who cannot be here today, for his support, and he can be contacted with this information as well. And thank you for your attention today.